Thank you.
All right. I guess we are already in the webinar platform. Right. Maybe we can start in a few minutes. Okay. Around 10:35. Okay, we will start our webinar now. Assalamualaikum. Very good morning to all the participants. Okay, welcome to the other session of the 32nd MACB Conference 2022. So we will continue our session with the next topic. The title of the topic is Updates on High Sensitivity Troponin, the Clinical Practice Guideline, Non-ST Elevation of Acute Coronary Syndrome 2021. So today we are fortunate to have a laboratorian, which is a chemical pathologist, Dr. Siti Haja Umar, to talk about this topic, because personally I consider this topic is a quite hot topic since last year. And most of the, these topics mostly spoken by the cardiologists. So still, we are fortunate to have the chemical pathologist to talk about this topic. So maybe I can read the bio of Dr. Siti Haja Umar. Okay, Dr. Siti Haja binti Umar is a chemical pathologist, actually at the Hospital Sedang. Forgive us, it's not in the Seberang Jaya Hospital. She is in the Hospital Sedang. So she obtained her medical degree from University Kebangsaan Malaysia, and in 2005, and of course pursue her master in chemical pathology in the same university. So she involved in the training committee as a committee member of National Pathology Training under Jawatan Kuasa Latihan Patologi Kebangsaan, and she also as a chairperson for still the same Jawatan Kuasa Latihan Patologi Kimia Kebangsaan. Okay, without further ado, I would like to invite Dr. Siti Haja to deliver her topic.
Thank you for the kind introduction. Assalamualaikum and a very good morning. First of all, I would like to express my gratitude to the organizing committee for inviting me to speak in this prestigious conference. Today, I will be sharing updates on hsTroponin, which is from the clinical practice guideline of non-ST elevation acute coronary syndrome, which was produced in 2021. As an introduction, ischemic heart disease has remained as principal causes of death in Malaysia. From the statistic of causes of death in Malaysia 2021, 17% of the 109,155 medically certified deaths in 2020 is due to IHD, followed by pneumonia and cerebrovascular diseases. Patients with IHD may present with stable coronary artery disease, CAD, which is now called chronic coronary syndrome or acute coronary syndrome, ACS. ACS is the clinical spectrum from NSTE ACS, which is a combination of unstable angina and non-ST elevation myocardial infarction, to ST elevation myocardial infarction, which is also called STEMI. From the pie chart here that was based on annual report of the Acute Coronary Syndrome Registry 2018 and 2019, the spectrum of ACS was similar to the previous cohort, with the most common presentation being STEMI, which is 43.4%, followed by non-STEMI, 32.1%, and unstable angina with 34.6%. Patients who presented with ACS remain young, with a significant proportion of 24.5% under the age of 50 years. The Malaysian National Cardiovascular Disease Acute Coronary Syndrome, which is NCVD ACS, registry in 2016 and 2017, it showed that our local in-hospital 30-day and 1-year mortality remain high despite being on downward trend, which is higher than those in other international registry. Now, what's new in the current guidelines? So, the CPG was the update of the previous CPG of unstable angina and non-ST elevation MI 2011, which was 10 years ago. In the previous CPG in 2011, there are few terms that are not discussed in the CPG and which is currently discussed in the current CPG. The first one is the use of term NSTE ACS. The previous CPG referred to as unstable angina and non-ST elevation MI. In the current CPG, it has used the term of NSTE ACS, which is a combination of unstable angina and non-ST elevation MI, which is also called non-STEMI. The second one is definition of myocardial infarction. There's no mention of definition of myocardial infarction in the previous CPG, and in the current CPG, it is in accordance with the fourth universal definition of myocardial infarction. The third one is distinguishing the difference between myocardial injury and myocardial infarction. The recognition that all myocardial injury is not necessarily due to MI. In the previous CPG, there's no clear differentiation between myocardial injury and MI, and in this current CPG, myocardial injury is reflected by a level above the 99th percentile upper reference limit of troponin, and myocardial injury may be due to ischemia or non-ischemic causes. MI is myocardial injury due to ischemia, and non-STE ACS is MI without ST elevation seen on the resting ECG. And the fourth one, the use of cardiac troponin, which is preferably high sensitivity cardiac troponin. In the previous CPG, there's no mention of high sensitivity cardiac troponin. In the current CPG, the recommendation for using cardiac troponin, preferably high sensitivity cardiac troponin, as the cardiac biomarker of choice in patients suspected to be having ACS. The guide on how to interpret elevated cardiac troponin levels is also shown. And MI is defined as a rise and fall in cardiac troponin levels and with either clinical history of in ECG or echocardiography, which is consistent with MI, or in the presence of an intracoronary thrombus. So the updates that I mentioned here is the one that is related to our practice, and there are a few other updates that is related to treatment and also prognostication. Now, when patient presented with chest pain, the provisional diagnosis that clinician will think of is acute coronary syndrome. So acute coronary syndrome is a clinical spectrum of IHD that develops because of an acute imbalance between myocardial oxygen demand and supply. So when patient presented with chest pain, the provisional diagnosis of ACS is made, and ECG will be done. And then we'll see whether there is ST elevation or not. If there is ST elevation followed by increased cardiac marker, diagnosis of STEMI is made. What if there's no ST elevation? Then we look at the cardiac biomarker. If the cardiac biomarker is normal, such as in unstable angina, myocardial injury is absent, and the cardiac biomarker will be normal, which is the suggested is cardiac troponin. And when there is a raise in by cardiac marker, this is due to myocardial injury, which results in cell necrosis. So myocardial infarction is a myocardial injury due to ischemia. So diagnosis of unstable angina is made if there's no elevation of cardiac biomarker. The diagnosis of non-STEMI is made when there's elevation of cardiac biomarker with absence of ST elevation. And both this unstable angina and NSTE AMI is called NSTE ACS. And the three unstable angina, NSTE AMI, and NSTE AMI is called acute coronary syndrome. We go to the unstable angina. Patients with unstable angina are a heterogeneous group of people. It's according to Brown-Watt classification, which was updated in 2000. Unstable angina may be classified into severity and also clinical circumstances. In severity, there are three classification, 1, 2, and 3, and also in clinical circumstances, the classification is divided into A, B, and 3. And if we look at the classification of 3B, there is positive results of troponin can be seen. So there's not all unstable angina do not have increased cardiac biomarker, but we see that the patient with in group 3B, there will be positive cardiac troponin. Now, myocardial injury and myocardial infarction. In this CPG, it is distinguished between these two. Myocardial injury may be due to ischemia, which is MI, and or non-ischemic causes, such as myocarditis or renal failure. And in myocardial infarction is myocardial injury due to ischemia and is defined pathologically as myocardial cell death due to prolonged ischemia. It is important to distinguish between myocardial injury and myocardial infarction. In this CPG, they mentioned that the cardiac biomarker of choice for the diagnosis of diagnosis are the cardiac troponins, both I and T, preferably high sensitivity cardiac troponin. The elevation of cardiac troponin indicates myocardial necrosis. And a level of 99 percentile upper reference limit is abnormal and indicative of myocardial injury. Cardiac troponin should always be interpreted in clinical setting. Many cardiac troponin elevation, especially below the cutoff point, and cardiac troponin elevation without a rise and fall are myocardial injuries and not MI. With the current definition, unstable angina patient in Brown-Watt classification stage 3B will be reclassified as NSTE AMI, which is non-ST elevation MI. Whether in this CPG also it is mentioned then where there is access to clinical to cardiac troponin testing, other biomarkers such as AST, LDH, CK, CKMB, and myoglobin are not useful for the initial diagnosis of acute MI. This is due to their lower sensitivity and specificity. CKMB may be used to monitor during infarction. In a setting where the cardiac troponin are not available, CKMB will be the alternate but less preferred option. After an acute MI, cardiac troponin becomes detectable after 6 hours using the conventional or the cardiac troponin AC and may remain elevated up to 14 days. A high sensitivity cardiac troponin AC detects cardiac troponin release at an earlier point than the older cardiac troponin, which leads to an improved early sensitivity for diagnosis of MI. Now further with we continue also with cardiac biomarker in diagnosis of myocardial and myocardial infarction. All hospitals providing care for patients with acute chest pain or suspected MI should have access to cardiac troponin, preferably high sensitivity cardiac troponin subtype T or I testing. It is inappropriate to label cardiac troponin result as positive or negative, and concentration for high sensitivity cardiac troponin assay should be expressed in nanogram per liter instead of the commonly used microgram per liter. This is because of the reporting of the result in integer will be clearer and safer for interpretation. The cut-off point differs among the different assay and the different generation assay by the same vendor. Some assay have set specific value, and female tend to have lower high sensitivity cardiac troponin levels compared to men. Cardiac troponin elevation is not exclusive for acute coronary syndrome, thus causing some problems in the interpretation of the result. It may present in 1% of healthy reference population. In a meta-analysis, about 47 of individuals had elevated cardiac troponin after an endurance training. And using high sensitivity cardiac troponin in most marathon runners, the result will be increased. In critically ill patient, the mechanism of an elevated cardiac troponin is unclear, and there is no consensus on the appropriate approach and management. False positive cardiac troponin with no myocardial injury results due to analytical issues are very rare. This includes cross-reaction from immunoreactive proteins and some neuromuscular diseases. Now we look at the history of documents on the definition of myocardial infarction. This occurred for the first time in 1950 and 1970s when working group from the World Health Organization (WHO) established a primarily ECG-based definition of MI intended for epidemiological use. With the introduction of more sensitive cardiac biomarker, the European Society of Cardiology (ESC) and the American College of Cardiology (ACC) collaborated to redefine MI using a biochemical and clinical approach, and reported that myocardial injury detected by a biomarker in the clinical setting of acute myocardial ischemia should be labeled as MI. However, the principle was further redefined by the Global MI Task Force, leading to a universal definition of myocardial infarction consensus document in 2007, followed by third universal definition of the myocardial infarction in 2012, and the latest fourth universal definition of myocardial infarction in 2018. So what is the fourth universal definition of MI? Myocardial infarction is a diagnosis when there is a significant rise and/or fall in cardiac troponin with at least one value above the 99th percentile upper reference limit and accompanied with at least one of the following: whether there is clinical history consistent with chest pain or ischemic origin of more than 30 minutes, is there any ECG changes of ischemia or infarction or development of pathological Q wave, whether there is imaging evidence of a new loss of myocardium or new regional wall motion abnormality, and identification of an intracoronary thrombus by angiography or autopsy. So in diagnosing NSTE ACS, the combination of history, physical examination, and electrocardiogram are important, but may not be sufficient to reliably roll in or roll out NSTE ACS. Troponins are raised due to myocardial injury, and this may be acute, which is associated with rise and fall, or chronic. There are other causes of raised cardiac troponin besides MI. The cardiac troponin assays could be laboratory-based or point-of-care kits. In general, point-of-care kits have lower analytical sensitivity and too wide coefficient of variation to detect cardiac troponin at the 99th percentile upper reference limit. Almost all locally available laboratory-based assay can measure cardiac troponin at the 99th upper reference limit. How do we interpret cardiac troponin? So in this CPG, it is also explained how is the interpretation of cardiac troponin is done. When there is elevation of cardiac troponin of more than 99 percentile upper reference limit, we look whether the cardiac troponin levels, there is rise and or fall of the level, or whether the cardiac troponin level is stable. So When the cardiac troponin level is stable, it is due to chronic myocardial injury, such as in chronic structural heart disease, chronic kidney disease. If there is a rise and or fall, with or without a fall in cardiac troponin level, with acute ischemia, it is due to acute myocardial infarction. So this acute myocardial infarction can be ACS or non-ACS. So ACS is due to STEMI and also NSTE ACS. And in non-ACS causes, it can be due to coronary or non-coronary causes that can cause increase in cardiac troponin, such as spasm, embolism, hypertension, and in non-coronary causes, it can be due to global hypoxia. And when there is the cardiac troponin elevation with acute ischemia, it is acute myocardial injury and it's not MI. So it can also be due to cardiac causes or non-cardiac causes. The cardiac causes can varies from heart failure, inflammation, myocarditis, pericarditis, infection, and stress or stress myocardiopathie. If the suspected non-cardiac causes, it can be due to sepsis, renal or renal failure. Bear in mind, we should not forget also the analytical errors that can also cause to increase elevation of cardiac troponin, even it is rare. It can be assay-based or sample-based, and the common cause of sample-based error is due to hemolyzed specimen. There are no clear guidelines as to rise or as to significant rise and fall of cardiac troponin levels. The criteria for determining a pathological rise between two serial cardiac troponin value are assay dependent. The National Academy of Clinical Biochemistry guidelines and expert consensus committee has suggested that in patients with possible ACS and baseline initial result cardiac troponin or hsTroponin result with marked elevation of more than 99% upper reference limit, changes in concentration of more than 20% from baseline should be used to define an MI. If it is less than 99% upper reference limit, and especially with high sensitivity cardiac troponin AC, with a change of more than 50 to 50% from baseline, has suggested to overcome biological and analytical variation. The AC used should have a coefficient variation of less than 10% at the 99% upper reference limit. Now we look at this illustration graph here. The illustration here shows an early cardiac troponin kinetics in patient after acute myocardial injury, including acute myocardial infarction. The timing of biomarker release into the circulation is dependent on blood flow and how soon after the onset of symptoms samples are obtained, whether it is very early, later, or very late. Changes in cardiac troponin values or deltas can be used to define acute compared with chronic events, and the ability to detect this is indicated in the figure. Marked elevation of more than 99% upper reference limit, changes in concentration of more than 20% from the baseline, as I mentioned earlier, should be used to define MI. And if less than 99% upper reference limit, and especially in high sensitivity AC, the change of 50 to 60% from baseline can be used to define MI. Increased cardiac troponin values can often be detected for this after an acute event. So if we look at the graph here, the stable line can be defined can be seen in chronic myocardial injury. And we look at the blood sampling. If patient is presented very early, and if we take the sample very early from the onset of symptom, the low cardiac troponin values is hard to detect a delta, so we cannot see any delta change. And if it is taken, the sample is taken early, the rising of cardiac troponin values from below to more than 99% delta is detectable, so we can see a delta change here in the early sampling. If later sampling also, we cannot see any delta, may not be seen over a short period. And the later sampling, which is very late sampling, we can see if there is a declining delta from the if it is more than 99% upper reference limit. Before we go further, it is important for each clinician to be familiar with 99% upper reference limit and the lower limit of detection of cardiac troponin AC used in their respective hospital. So now from this graph, we can see that the term that is commonly used in the CPG, the limit of blank is represent the noise signal inherent in analytical system. LOB is the 95% of analytical signal when no cardiac troponin or zero nanogram per liter is present in sample tested. Limit of detection is the mean signal at which 5% of the frequency distribution is below the LOB, meaning that 95% that cardiac troponin is present in the sample, and LOD is always exceeds LOB. The limit of quantitation, the green one, represents cardiac troponin value at which the value can be reliably reported as a number. Limit of quantitation is typically cardiac troponin concentration where AC total CV is equal to 20%, and LOQ always exceeds LOD. And the upper one, the percentile, is the clinical decision value at the 99th percentile, with the male cutoff is more than overall cutoff and female cutoff, and the female cutoff is usually the lowest. Set-specific cutoff should be used for interpretation with high sensitivity cardiac troponin AC. So okay, we continue with high sensitivity cardiac troponin. The high sensitivity cardiac troponin AC is currently replacing the conventional cardiac troponin AC in the market. The term high sensitivity reflects the AC characteristic and not a different type of cardiac troponin. A high sensitivity AC must meet two criteria. First, have a coefficient variation of imprecision of less than or equal to 10% of 99th percentile upper reference limit, and have a measurable concentration below the 99th percentile. They are attainable with an AC at a concentration value above the AC limit of detection for at least 50%, ideally more than 90% of healthy individual. So if we go back to the previous graph, at least we should have at least more than 50% of the healthy individuals' troponin level should be detected at the AC limit of detection. Preferably, it can achieve 95% from the healthy individuals' troponin. According to the guideline, for qualified determination of 99% the upper reference limit for a contemporary cardiac troponin AC, a population of at least 300 healthy individuals is required with an appropriate age, ethnic, and gender mix. However, in the case of high sensitivity AC, the 99th percentile are gender specific, so at least 300 healthy females and 300 healthy males should be tested to achieve this cutoff. At present, most commercially available high sensitivity cardiac troponin AC attain at coefficient of variation of less than 10% at the 99th percentile, indicating that the result is less affected by analytical noise and is a bit lower in the test variability. Good pre-analytical sampling is important, as the high sensitivity cardiac troponin AC are so sensitive that poor sample quality, most commonly hemolized specimen, can be a problem. High sensitivity cardiac troponin can be used to rule in MI when there is significant rise and or fall of cardiac troponin with at least one value greater than 99th percentile upper reference limit in combination with other clinical criteria, or rule out MI. Rule out doesn't equate to discharge. It requires consideration of other causes of chest pain, early rule out patient assessment for possible coronary artery disease, or optimization of care in patients with known coronary artery disease. So there are issues in high sensitivity cardiac troponin measurements. Almost 13% of patients presenting with high sensitivity cardiac troponin and chest pain eventually proven not to have MI. This may reflect myocardial injuries and not MI. Many primarily cardiac disorder as well as non-cardiac disorder with cardiac involvement may lead to myocardial injury and thereby high sensitivity cardiac troponin elevation. That's why interpretation with clinical correlation is very important. The Slides after this shows the elevation of cardiac troponin in the absence of overt ischemic heart disease. So it can be either due to damage related to secondary myocardial ischemia, such as aortic dissection, acute coronary heart failure without significant concomitant coronary artery disease, hypertrophic cardiomyopathy, or coronary vasculitis. The second one, it can be due to damage not related to myocardial ischemia. It can be due to cardiac contusion, cardiac incision with surgery, rhabdomyolysis, myocarditis, or cardiotoxic agent such as anthracycline and herceptin. It can also happen in severe burns. And the second one is indeterminate or multifactorial group. This can be due to severe pulmonary embolism or pulmonary hypertension. It can happen in renal failure, in severe acute neurological disease, or in sepsis and extreme exertion. Now we look at the range of diagnosis across high sensitivity cardiac troponin. This graph shows that a broader differential diagnosis is associated with a lower range of high sensitivity cardiac troponin. The lower part is the results in healthy individuals, and when it is increased more than 5, it can be due to stable angina, heart failure, or left ventricular failure. And when it is 99% upper reference limit, it can be suspected of having MI, but can also be due to other causes such as myocarditis, stress cardiomyopathy, PE, or hypersensitive crisis. But when the results is getting higher, the diagnosis narrows to myocardial infarction and myocarditis. How about point of care testing? The clinician must be familiar with their local cardiac troponin assay, whether it is point of care kits or lab-based. Use of point of care kits in areas without access to central lab could potentially reduce unnecessary referrals or transfer of cases and results in overall cost saving. Even though point of care kits have a rapid turnaround time, it is not sensitive. So when using point of care kits, when the reading is elevated, admit the patient for further evaluation. If the reading is normal or non-detectable and the clinical suspicion is high, repeat after 6 hours to evaluate the patient. In guidelines recommended turnaround time for cardiac troponin or hsTroponin is 60 minutes and do not recommend high sensitivity cardiac troponin assay provided along with cardiac troponin. So POCT of cardiac troponin is actually not recommended to be present when the assay in the that is offered in the lab is high sensitivity cardiac troponin, because this can lead to confusion by clinician. Okay. Now we go to triage or risk score for NSTE ACS. When patient presenting with chest pain or chest pain equivalent, we can look at clinical history and ECG. The patient may have a very likelihood of NSTE ACS or have an alternative cause for their symptoms. This can be treated accordingly and be discharged from the emergency department. And if the patient have definitive ACS or NSTE ACS, this patient should be admitted and managed appropriately. If the patient is a possible or suspected NSTE ACS, the patient have a normal or non-diagnostic ECG and need to be evaluated using rule-out protocol for ACS. An evaluation is a continuous process, and it is possible for a patient to move from very likelihood ACS to definitive ACS as disease evolve. Patient with possible suspected NSTE ACS should be re-stratified using HEART or modified heart score or TIMI score and evaluated using the rule-out ACS. Following evaluation, this patient may be discharged from ED or referred for an outpatient cardiology or to the medical if there's no cardiology in the hospital, or admitted for further observation and management. So this is the flowchart for the rule-out protocol for patients suspected to have ACS using cardiac troponin, which is preferably high sensitivity cardiac troponin, and 0 to 3 hour protocol. So when patient presented with acute chest pain after history and physical examination, their cardiac troponin level is measured, and preferably high sensitivity cardiac troponin. If the result of troponin is more than 99 percentile, the patient should be admitted. However, if the result is less than 99 percentile upper reference limit, we can see we have to see whether the cardiac troponin level is taken less than 6 hours after onset or symptom, or if it is a cardiac troponin, or less than 2 hours in high sensitivity cardiac troponin after the onset of symptom. So if it is risk, repeat the second cardiac troponin 3 hours later with cardiac troponin. If high sensitivity cardiac troponin, we should repeat 2 hours later. If the result is still less than 99 percentile with less than 50% change in levels within a 3-hour period, but still having pain and or heart score of more than 3, and TIMI score more than 2 and other diagnosis, this patient should be admitted. If the result is more than 99 percentile or more than 50% change in levels within 3-hour period, this patient should also be admitted. When the result is less than 99 percentile, and then the cardiac troponin level is done more than 6 hours after the onset of symptom, or high sensitivity cardiac troponin done more than 2 hours after onset of symptom. If the patient is pain-free and heart score or TIMI score is low, this patient can be discharged for early outpatient cardiology appointment, or if there is no cardiology appointment in that hospital, it can be referred to medical outpatient clinic for further management. So the common roll-out risk score that I use are heart score, which is history, age, ECG, age, risk factor, or troponin score, TIMI score, and ADAPT or aspect, and Heart Foundation of Australia, Cardiac Society of Australia and New Zealand, HFA, CS, and group. The heart score is the commonest risk score used in our emergency department, although there have been no validation studies in our local population. Despite its use in different patient population, the cardiac troponin type use and timeline of follow-up, the low risk heart score had high sensitivity, negative predicted value, and negative likelihood ratio for predicting major adverse cardiovascular events. Based on the heart score, patient with suspected ACS can be stratified into more than 7, which is high risk, or intermediate risk, or low risk. The modified heart score uses high sensitivity cardiac troponin rather than cardiac troponin. Now we go to the TIMI score for unstable angina and non-ST elevation and on. The TIMI score is determined by the sum of the presence of 7 variables at the admission, 1 point given for each of the following variables, and one of it is elevated serum cardiac biomarker, preferably high sensitivity cardiac troponin, and the total score will be 7. The low risk when it is less than 2 points, moderate risk when the point is 3 to 4, and high risk more than 5 points. The TIMI score, although commonly used, was not designed for application to undifferentiated patient presenting with chest pain and suspected ACS. To improve its performance as a rule-out risk score, modification have been studied, including using cutoff of 0 to 1 for lower risk. In a prospective cohort study, in conjunction with single contemporary cardiac troponin assay taken in admission, the heart score outperformed the TIMI score, TIMI and GRACE score in predicting 30-day MACE. About 2.1 to 3.3% of ACS patients are, however, missed by the heart score. Thus, clinical judgment is still important before discharging the patient from ED. Persistent or recurrent symptom during ED stage should prompt the clinician to re-evaluate the patient. It is important to remember that these risk stratification strategies, rather than definitive diagnostic strategies, further investigation may be necessary to determine the cause of chest pain. When patient with definite NSTE ACS, they should be re-stratified using either clinical feature, TIMI, or GRACE risk score. Okay, these are the clinical feature score, which can be divided into very high risk criteria, intermediate risk criteria, and low risk criteria. So we see here that the GRACE and the TIMI score is also used to determine this criteria. This is the TIMI score charting and the scoring from lowest to the highest, which determines the all-cause mortality or new or recurrent MI or severe recurrent ischemia requiring urgent revascularization. This is the GRACE score. This GRACE score risk scoring chart here. There is the elevated cardiac enzyme is also used in the scoring of GRACE score. How about low risk patient? When a patient is low risk with no angina in the past, no ongoing angina, no prior use of anti-angina therapy, no normal ECG, normal cardiac biomarker, younger age group, and with normal left ventricular function, we see whether patient have normal ECG and good exercise tolerance, or whether has a normal ECG with limited exercise tolerance. This will lead to the further management done. If it is normal, then the patient will be guided to exercise stress test. And if it is negative, the patient will be suggested to have risk factor reduction and with medical therapy for coronary artery disease. If it is abnormal, ECG with limited exercise tolerance, or the exercise stress test is equivocal or positive, both of these groups will be recommended for invasive coronary angiogram. So this patient should be advised on lifestyle modification with dietary changes, regular exercise, and cessation of smoking. If the likelihood of underlying coronary artery disease is high, they should be started antiplatelet agent, high intensity statins, and appropriate anti-ischemic therapy. So the risk score for prognostication, this score are also used for prognostication. That's why I'm mentioning it here, because all these scores uses biomarkers as one of the part of the assessment. So the risk scores for prognostication use can be a clinical feature or risk score such as heart score, TIMI score, and also GRACE score. TIMI or GRACE risk scoring is recommended in this patient with definite NSTE ACS. This risk score helps dictate the appropriate strategy, whether invasive versus ischemic guided, and the timing of strategy, whether early versus late invasive in patient with NSTE ACS. The very high risk and high risk patient should be considered for transfer to a PCI capable center as soon as possible. So this is my last slide. As a summary, cardiac biomarkers, especially troponin or preferably high sensitivity cardiac troponin, complements clinical assessment and 12-lead ECG in the diagnosis, risk stratification, treatment, and prognosis of patient with suspected NSTE ACS. Measurement of biomarker of cardiomyocyte injury, preferably high sensitivity cardiac troponin, is mandatory in all patients with suspected NSTE ACS. And cardiac troponin are more sensitive and specific biomarkers of cardiomyocyte injury than creatine kinase, its myocardial band isoenzyme CKMB, and myoglobin. And if the clinical presentation is compatible with myocardial ischemia, then a dynamic elevation of cardiac troponin above the 99th percentile of healthy individual indicates MI. Okay, these are my reference. Thank you. I hope this sharing benefits all of us.
Okay, we would like to thank Dr. Siti Haja for a very informative lecture about this the new CPG. I think we will straight to the Q&A live session with Dr. Siti Haja. Dr. Siti Haja, you are unmuted.
Okay, right. Yes. Assalamualaikum.
Okay.
And very good day.
Dr. Siaja, before you are able to answer all the questions in the Q&A platform, we have some question here with me. I think the first question will be the prognostication for TROP-I. What is the experience in Hospital Serdang? Because you know the TROP-I is considered a bit expensive testing, right? So did type of procedure has been applied in Hospital Serdang?
Yes. Actually, prognostication is also used, but as I see here that mostly in Hospital Serdang, they use it more on diagnosis based for the diagnosis, because actually the price is also high for troponin. So what I saw here that mostly is most commonly used for diagnosis, whether to differentiate whether it is ACS or non-ACS. If there is a delta change, then they will the positive delta change, then they will give diagnosis of ACS.
All right. So do you have any idea about any other hospital that use this as a prognostication in Malaysia? Perhaps the last.
That one I have to go further. Maybe I have to ask the cardiologist to answer correctly.
Okay. The second question will be the role of hsTroponin in the PIT setting, maybe in the children, such as myocarditis post-COVID. Any experience that you would like to share in Serdang?
Yes, I think there is also some requests for from pediatric department. We still run the test, but actually the use of troponin in pediatric, the significance in of the AC results in pediatric is still debatable, because cardiac coronary artery disease is very rare in children. Even if there is any patient have cardiovascular disease, the result is still debatable.
Right. I think last question about this, I think this type of clinical questions. What is your opinion when clinician request troponin in the setting of the post-CPR?
I don't think many requests of post-CPR for troponin, but I think the requests can be made when there is a indefinitive cause of death for patient with post-CPR. Maybe they do not know what is the cause. So if they send, then there is indication for to know the cause of death. We will run the sample. But bear in mind, we have to give some disclaimer that the result should be interpreted with caution.
All right. I think now we can refer to the Q&A platform, Dr. Haja. I think maybe only a few because of the time constraint. The rest, I think you can answer it later using this platform.
I hope you can read the question for me, because I rejoin again, so I cannot read the question.
Okay, I think the secretary will handle that after this. I can read a few questions here. Okay, the first one on the chatting platform is, do you lab provide comment in the lab report to inform clinicians that there were 20% fall or rise of cardiac troponin compared to previous result or baseline? I think that is a question. What is your opinion? Does lab need to put this comment, or we let cardiologists to estimate themselves? I think it's a good question.
Okay, for you all that maybe not familiar with Hospital Serdang is actually a cardiology center. So when it's cardiology center, the request for cardiac troponin is very high here. So we are unable to give any interpretation for each result. So the release of result is usually made by MLT. So we do not give any comment on the report. But for further improvement, maybe we can use the report as an auto comment, so that it is for educational purpose for the clinician.
All right, we still have time actually. In your opinion, shall lab reject hemolyze sample for high sensitivity troponin?
We do not reject, because troponin is also considered a pressure sample, because patient do not come easily with having chest pain. So we do not reject. So we will try to run as we can. But if it is very grossly hemolyzed, so and we cannot run test, it cannot be it's cannot be analyzed. So we do not proceed with comments in that.
To avoid any ethical issue, right? I think I agree with you.
Yes.
The next question will be since it was removed. Since the importance of the sex-specific cutoff, do you think all the labs should use it? Sex-specific cutoff.
That question, it depends on the platform that you are using in your hospital, and it depends on the troponin variability that you offer. Usually the cardiac troponin or troponin T, usually the one that has set-specific cutoff is usually the hsTroponin I. So if there is cutoff in the insert kit that shows that it is set-specific, you should verify it when during the method verification and release the result range as it is recommended.
Okay, Dr. Setiaja, I'm afraid that we are running out of time because we need to move to the next webinar. I think you can stay on this platform and please answer all the questions on the Q&A platform, or perhaps our secretariat will contact you how to get back all of these type of questions. Okay. So in this case, any last remarks from you, Dr. Setiaja, before we end the webinar?
I want to congratulate MECB for this program. I want to take this opportunity to congratulate you all and thank you. I hope the talk benefits all of you and you understand all what I have given.
Okay, we'd like to Dr. Setiaja, and to all the participants, please feel free to fill up the the evaluation form. You can simply click on the reaction button on your right panel. Okay, then together we will leave the webinar to the next session. Okay, thanks to Dr. Setiaja.
Thank you, Amin.
Okay.
I'm not sure whether Marina, are you here?
Dia kat bawah tu ada backstage kan, ada tekan backstage.
Backstage macam mana nak jawab yang soalan?
Nanti kita pergi backstage.